shoes to fill following Robin Phillips in his wake. But he's an excellent speaker, perfect speaker. He's going to talk to us about management fistula notes, new options.
Thanks very much, Chris. Do I have to do this that sounds very prima donna-ish, doesn't it? Do I have to do this myself? Do I? I just do it on that. Very good. Thanks very much. So I was asked to talk about what's new in anal fistula, and that assumes a bunch of knowledge about what's old in anal fistula, which I have done. And I hope that's okay, but I'm afraid I'm not going to be around for the round table later on, so if you've got any questions at the end, then do throw them at me if that's okay from Chris's point of view. And those can be about some of the more basic principles if you wish. Just a brief disclosure. This is the gang upon whose behalf I speak whenever I do. This is our fistula research unit here at St Mark's. So we're going to talk about the emerging treatments. Now, we all know in surgery that if there are 20 ways to do something, as there are in the surgical treatment of anal fistula, that means there's no good way to do that thing. Of course, there is a good way to cure anal fistula, and that's to lay them open. It's a really effective treatment. The problem is that it carries a continence impairment risk, and we're pretty good, I think, at quantifying that now. We did some work on it here, but broadly speaking, any patient whose fistula you lay open, whether it is intersphincteric or transsphincteric, as long as it doesn't get too high, and we can talk about what that means later on if you wish, will suffer a risk of around 1 in 3 of difficulty controlling wind and skid marks, as long as their bowel habit's okay and so on. There's a lot of caveats there. That's a whole talk in itself. That's the stuff that we're not going to talk about today unless you want to. As a result of the fact that laying open runs into that risk of continence impairment, that means it's not right for every patient, and it means it's not right for every fistula. And for that reason, we have developed these things, the sphincter preserving procedures. And it's some of those that I'm going to talk about today. Now, there's an enormous variety of those. Here are some of the ones that you will have heard of. But actually, there isn't quite so much variety as we think, because broadly all of the different sphincter preserving procedures are aimed at 1 or perhaps 2 principles in terms of treating anal fistula. So, for example, over there, as you look at it in the top right-hand corner, you've got different ways to disconnect the fistula tract from the gut. The old-fashioned advancement flap, the somewhat more modern lift procedure, and then the over-the-scope clip. And all of those do is disconnect the rest of the tract from the gut. The lift perhaps has a slightly more enhanced mode of action. And I just want to say a word about sphincter preservation, because I've told you that these are the sphincter preserving procedures. And of course, we all know that there are some treatments that divide the sphincter. Don't be fooled, by the way, into thinking that tight cutting or snug setons or chemical setons or any other type of seton isn't cutting the fistula. It is, and it carries the same risks of impairment of continence as doing it in one day. And there are those which genuinely preserve the sphincter, have no impact on the sphincter. And then there are those in between. And the big one there is advancement flaps, which people think about as a sphincter preserving procedure. But the thicker the flap you take, the more likely it is to survive, and therefore the fistula to heal and not to recur, but also the greater risk there is to continence impairment. And if you take a full thickness flap, you're dividing the internal sphincter, and that means you carry that same 1 in 3 risk, probably, of difficulty controlling wind and skid marks. So don't be fooled by the advancement flap as a principle. But remember also that recurrent failure that we might well see in the sphincter preserving techniques with recurrent abscess generation will also potentially damage the sphincter. And we see this particularly in Crohn's disease, but also in really recurrent, recalcitrant, idiopathic anal fistulation as well. Recurrent abscesses destroying the native tissues and leading to impairment of continence. So, what we're going to talk about now is this question. When one is faced with a fistula that you can't lay open and you don't want to leave with a seton, how should the surgeon decide which sphincter preserving procedure that they want to undertake? And that's mostly about unsuitability, and here are a few examples of unsuitability. So, with an advancement flap. You wouldn't do it if there were rigid and scarred tissues and you weren't going to be able to advance the tissue down through the rectum and the upper anal canal to cover the internal opening. You can't do FILAC, which is the laser we'll talk about in a few moments, if it's a very wide tract, if there's a big cavity, or if there are side branches, for example, and so on and so forth. I think lift is a worthwhile candidate for discussion here because lift is a lovely procedure. It's great fun to do and it's really nice for the straight transsphincteric tract. There's quite a lot of situations in which you can't do it, and it may well be a procedure that you're coming across during the course of your training. So this is the schematic, the diagram from one of the lift papers. If you look in any of the lift papers, there's a different set of diagrams like this one that show you broadly how to do it. But the principle is an incision in the intersphincteric space running between the internal and external sphincters to identify the fistular tract there in B, and then you ligate or transfix it in C, either side of the intersphincteric space, up against the external sphincter, up against the internal sphincter. Divide the tract, maybe excise a bit if you can, and then close up your wounds, give the patient antibiotics and cross your fingers. So, patient selection for the lift procedure is actually, I think, quite difficult. Everyone talks about single straight transsphincteric tracts. I think that's quite right, and people say that intersphincteric complexity is an absolute contraindication to this procedure. I agree with that, but I think there's a bit more to it. For example, there has to be an appreciable intersphincteric space. That's the space in which you're going to try to work. So, for example, if the patient's had a previous drainage of an intersphincteric abscess or an intersphincteric horseshoe around the area of the intersphincteric space, that whole area will be scarred, there'll be a loss of the internal sphincter, it will all be stuck together, and there won't be an appreciable space in which to work. And in my view, that means that you can't do the lift procedure very successfully or easily in that situation. I also think that the internal opening is very important here, and it can't be too wide or deep. Sometimes the internal opening reaches in like a cup through the internal sphincter into the intersphincteric space and really only stops at the level of the external sphincter. And for the same reason, it's very difficult to work in that space and obtain closure of the fistula. Very easy in that situation to run into the anus by cutting into the internal opening. And I think the other question is about traversing the intersphincteric space. And it's often said that this is the procedure you'll use when the fistula is too high to lay open. Well, if it's too high to lay open, you might run into this problem. When I draw out the anus and the rectum, I draw it in the shape of a champagne flute. I guess many of us do. But it isn't that shape. It's actually a Marie Antoinette champagne type glass, right? Particularly posteriorly and at the sides, the rectum bulges out to sit along the pelvic floor for a while. And that means that when you do your operation and you're working in the space around the fistula, if the fistula is too close to the top of the intersphincteric space, too close to the anorectal junction, then the space you're working in is right up here. It's hard to reach, which is what everyone always says, but more importantly, in my view, it means that when you get round the back of the fistula to try to do your transfixion, you have a real risk of running into the champagne glass, which is the rectum, damaging the rectum, creating a second opening, creating a new internal opening in the rectum in addition to the one which will recur in the transsphincteric style in which it started. That's a real shame, of course, because you've probably rendered that fistula incurable. So it's a real problem going too high with these fistulas. I think it's also worth mentioning about lift failures, because I suspect when people consent about the lift procedure, they talk about failure very broadly. I think it's generally accepted now that lifts tend to fail in one of three ways. These are the three laid out in a really nice paper by Tan. And it's particularly the last one that I want to talk about. If you get an intersphincteric abscess or an intersphincteric fistula that recurs, you can call that a win, because you can probably then go ahead and lay the fistula open without too much concern. But if you get a transsphincteric recurrence, some of the time you will also get recurrence in the intersphincteric space. And so you've then got two external openings, one internal opening, and the fistulas become more complicated. And as far as the patient's concerned, they came to see you with one fistula, you've done a fancy operation, and now they've got two. And they will not be your biggest fans on iwantgreatcare.com. So, like the lift procedure, all of the sphincter-preserving procedures demand a specific fistula morphology, and that's really the key of that segment of my talk, more of which in a moment. How often do these sphincter-preserving procedures work? You can't believe I'm going to talk about all of them as a group, but that's exactly what I'm going to do because there's so many of them. It's very difficult to differentiate them, and actually there's very limited evidence amongst them. So I'm going to give you the wise words of two of our great fistula doyens of this generation, one of whom is still working, Andy Williams, who says that fistula treatments, not laying open, but sphincter-preserving procedures, are successful in no more than around 60% of patients, regardless of what the literature says. Robin Phillips is a little bit harder to please. He thinks that lift and advancement flaps probably work around half the time, plugs never healed anyone, and anything else is howling at the moon. His words. Why is that? Why don't these treatments work? Well, again, there's another hour and a half's lecture here that we're not going to go into. This is my view about why they don't work. I think we're treating a multifactorial problem in a unifactorial way, and we all know that when we try and treat a multifactorial problem in a unifactorial way, we are just trying to ice skate uphill. So, finally, I'm going to talk about three of the newest treatments: Phylac, VAFT, and stem cells. This is Phylac, fistula laser closure. Arnie Wilhelm is the guy who first published it and still has the biggest series. This is the laser fibre. It fires out in all directions at once, like an epileptic lighthouse. And it will burn the fistula from the inside all the way down as you pull the fibre through. And you can see on the right there, that piece of steak, that it produces a controlled burn of the tissue, which is nice. It means you're really debriding the tissue very effectively from inside. It's a very straightforward procedure, which is one of the other reasons that people really like it. You just stick the probe in to the correct fistula, burn and pull it through, and then close the internal opening. And it's great if you've got a straight, non-branching transsphincteric fistula. As I say, Arnie Wilhelm has the biggest series. He reckons he gets about 65% success rate. Interestingly, he says it's the same in Crohn's, although, as with all fistula papers, it's a very much smaller group in Crohn's disease, identified as a subset within his case series. I think wider tracks are much more likely to fail because I think the laser energy is not reaching, and because the fistula tissues are not able to collapse in quite the same way. And for that reason, Arnie reckons that if you do this through the external sphincter, you get a much better seal and a much higher chance of success than if it's just through the internal sphincter. Complications, and this is the same for all of the treatments that I'm going to talk to you about, it's really about recurrence. A recurrence sometimes via an abscess, and that's really what I think you have to tell the patients about. Quite often, I think because you leave the external opening to drain in these procedures, it will simply never stop draining, and so the patients just think you haven't really done anything, just wasted a few days of their annual leave. But just sometimes the external opening will heal, it will develop into an abscess, and then usually burst out through the same external opening. And I think patients need to know about that. Video-assisted anal fistula treatment, published first and foremost by Miniero, and I call this curative VAFT. This is a particular way of using the telescope inside the fistula to cauterize under direct vision the internal surface of the fistula. You can imagine it does kind of the same job as the laser in that sense, but you can get it into a side branch if you like and treat that area too. He originally published this stapling the internal opening closed. My own view is that staples have no place in the anus. He then moved on to advancement flaps, and sometimes now he and others simply close the internal opening. And that's what we do when we're doing it. There's a few more papers, and the biggest ones I've highlighted in red there, Miniero and Chowby, and they both reckon they get about 3/4 of patients healed with this. The devil is always in the detail with these things, isn't it? And I suspect their patient selection is extremely careful. And this is a slide from my thesis, which is why the last study on there is from 2010. I can tell you things haven't changed for the better. Most fistula treatments go through this pattern of very high success rates early on, which drift away over time down to 30, 40, 50% success in the later series when everyone's getting to grips with it. And that may be because people are not doing it so well, but my own view is that it's because we're reaching the true equilibrium. This is what's genuinely happening. And I think we have to apply that same logic to Phylac and VAFT as time goes forwards. But I think VAFT has a lot of other exciting features. This is one of our research fellows, Sam Adegbola, and he published a little bit of work using VAFT for palliation in Crohn's patients whose fistulae will not heal. And what we showed in an unblinded series was that pain and discharge improved in most patients when we treated it simply by cauterizing the inside of the tract, which we take to believe is because we're reducing that inflammatory burden of the tract. Although, as I say, it was unblinded, and there's a big placebo effect with any kind of surgical procedure. So these data are unproven. This is another use which we have developed here for the VAFT scope, and you can see a video here on the right of me using the VAFT scope to try and get around this very difficult fistula. There's two right angles in this fistula. It's very difficult to get a probe through the two right angles, one in the insphincteric space and one round at the back to come through to the internal opening. And you all have seen fistulas like this with bosses struggling to get a probe through. And the old-fashioned approach was to make a big circumanal incision outside the muscle and straighten out one of those two right angles. But you can actually use the VAFT scope to get up to the outer of the two right angles, through that and to the inner of the two, and you can place a probe with a aceton on it through the internal opening to the inner of the two right angles, grab the aceton and pull it through, and in that way you get to place the aceton through this difficult fistula without making a big cut. And this is a genuine minimally invasive surgery advantage to the technique. So it's another way in which we use VAFT. And one of the frontiers that we're working at is what we call the staged repair. And this is changing the morphology of the fistula. I've talked about unsuitability of some fistulae for sphincter preserving procedures. Well, what if the patient hasn't read that particular brilliant paper that I've written about it, and they come in with an unhelpful fistula that has a side branch in the insphincteric space? Well, we ought to be able to try to deal with that and convert them to the fistula, the transphincteric fistula, which we can treat with one of these techniques. So sometimes it's straightforward and we can drain cavities and combine tracts outside the external sphincter, so in the ischioanal fossa, and you'll have seen that done, I'm sure, a number of times. And sometimes we can lay open an intersphincteric horseshoe or extension or a supralevator extension into the anal canal, but we're dividing internal sphincter, and that means that same 1 in 3 risk that I talked about earlier on. So what about taking a minimally invasive approach to those cavities? There's the easy one, which we might drain from below, bang in aceton and hope that it will settle down. This is a slightly more difficult one, and maybe we can use DVAF, D for delta, changing the morphology of the fistula, to get into that space and close that area down. That's very much a work in progress, which means it may not work. We're looking at it and we'll let you know. Stem cells, coming towards the end now. Amy Leitner very helpfully did a systematic review on stem cells and, broadly speaking, suggested that they improve efficacy of other treatments without any increase in adverse events. I'm not going to go through these data in detail. I will just mention the ADMIRE-CD study because many of you will have heard about it. This was the randomized controlled trial, just over 200 patients in perianal Crohn's disease, mostly treated medically, although not all of them, and given either CX601, now called Aloficel stem cells, as an injection around the fistulas, or given a control injection of saline, and that's done under anaesthetic, and of course the patients were blinded. They used combined remission, meaning clinical and radiological healing as their outcome. Now, there are flaws with that endpoint, but it's a much better endpoint than any of the medical trials, which all used clinical remission only. And so we can believe a little bit more what we're hearing from this study than we can from some of the medical studies, in my view, although still not completely. And what they demonstrated was a 15% uplift in fistula closure, they call it healing or remission, between the placebo arm and the Aloficel arm. Now, this raises more questions than it answers, in my view, but it's an interesting step which we and others are keen to look at going forwards. So, in summary, most of the sphincter preserving procedures probably work around half the time, or perhaps less. Some of them risk damage to the sphincter to some degree, and be clear about that with yourselves and with the patients when you're consenting them. And all of them require a specific fistula morphology in order for you to be able to use them. Stem cells, well, we're really at the beginning of our knowledge of stem cells. It'll be a few years before we determine whether they're of any real benefit. They may well not be. But FILAC and VAFT, although they're also at the beginning of their journey, particularly VAFT, in my view, has a much greater utility for anal fistula. And when you become a consultant in your new hospital, wherever you end up working, I suggest you buy one of these and play around with it for a while, and I think it changes the way we think about and understand anal fistulas. And I think changing the morphology of fistula tracts is going to be a key weapon in our arsenal going forwards. And there's much more to be said about that in the coming years. Thanks very much.
Now, we haven't got Phil for the end of the session, so I wonder if there's any questions that might be fielded for Phil whilst we've still got him. Has anyone been? Well, you're not really allowed, but I suppose we might let you break the earth. Feel free, yes. Here's some. You can ask your one first. Simon.
Oh no, I feel bad going first. Very nice talk, thank you. You mentioned closing the internal opening. You don't use staples or clips, so how do you do that exactly?
Just with sutures. And I think when people talk about an advancement flap to close the internal opening of one of these things, I don't think they genuinely mean a big advancement flap that they're preparing in the way that we all think of when we talk about advancement flaps. I think what they mean is that they're undermining a little bit around and about to relieve tension and then closing. And I'll tend to use 4 or 5 interrupted 3-ovicral sutures on a tiny needle, having undermined a little bit, and then bring the edges together, broadly speaking.
Yeah, thank you. It was a very interesting chat. I haven't seen any of these new techniques at all.
Yes.
I've only seen loose setons and an advancement flap a couple of times. I'm an ST8 and colorectal. Can you just clarify, is there any role, do you think, for a cutting seton? Because I've never seen one, and I've never seen any bosses recommend it. And obviously it's still being talked about in books and things. I know it's not...
Yeah. So Prof. Phillips had an interesting thing to say about textbooks, which is it's the place where errors get multiplied. And everyone writing their new textbook looks in the old textbook and kind of copies everything out. There are still people that use the cutting seton. There are people who will try to convince you that using a cutting seton prevents some of the continence impairment associated with a lay open. There is no evidence to support that assertion in my view. I have a different reading of it to those people. There's something to be said about fibrosis, meaning that the wound doesn't spring apart, and if you're making the argument that the contour of the anus changes less, okay, there's an argument to be made for that. Whether you want 6 or 8 weeks of pain as a payoff and whether there's a genuine benefit, again, remains to be proven. In my view, no, but there are still people that use them. The trick is not to use it in a patient where you wouldn't do a lay open. That keeps you safe.
Hi, thank you very much. I have a technical question about the lift procedure. How do you deal with the surgical space afterwards, the intersphincteric space? Do you drain it? Do you just close it? Do you stagger the 2 openings around the...
No, you just close it. It's a good question. You just close it and you give them antibiotics and you kind of hope, and sometimes that wound breaks down, and that's the first type of failure. It will often just drain itself, or antibiotics alone will mean it settles down and the fistula doesn't recur. But it's, yeah, broadly speaking, you just close the space.
You don't drain it or...
No.
Any other questions? Excellent. It seems to be a good prop.
This is probably a really simplistic question, but which patients wouldn't you do the loose seton in? Just sort of wait for things to settle down?
Yeah.
Or do you do that first and then try and do
Yeah, okay.
So
there's...
you never get there with loose seton?
So there's...
Sure it was
yeah, I think that's the point he's making.
Fine, sorry.
So the question was essentially, when do you use a loose seton? I think there are 2 reasons to use a loose seton. One is palliatively in the long term. In the patient where sphincter preserving procedures have failed or aren't suitable, or they're not interested in them, and you can't lay them open, or the patient doesn't want you to lay them open, you can place a loose seton, and that can be good for them forever. They're really useful in Crohn's disease in that situation when they're comfortable. Patients sometimes say that the loose seton isn't comfortable and my seton's hurting. My view is that that's usually probably the fistula that's causing the symptoms rather than the seton, but it does depend on the type of seton you used. John Northover always used to say palliation should palliate. What that means in this context is if you're putting in a seton, don't make it made of barbed wire. Okay, use something comfortable, soft, light, small with a small knot. We use Ethibond tie back with silk. It's nice and comfortable. The other reason for using it is to mature and prepare a tract prior to a sphincter preserving procedure. And pretty much everyone does that, although there isn't really good evidence. There's a little bit of evidence that it's helpful. There isn't really good evidence for it, but pretty much everyone does it. So drain the abscess, mature the fistula with a loose seton, then go ahead and do your SPP.
Any questions?
Quick question. patients do you get imaging on before you undertake treatment, or is that based on clinically what you see before you do operate, or is it ones that have recurrent problems, or?
Yeah, so anyone who I think has a complex fistula when I examine them, or a recurrent fistula, which means they probably have a more complex fistula than I thought the first time, or a person in whom I'm planning a sphincter preserving procedure because a missed extension in that situation is lethal to the repair, it will recur. Those are the patients in whom I will get an MRI scan. If I can assess them in clinic and I'm confident that it's simple and that I understand all of its ramifications, and my plan is either to place a seton or to lay it open, then I won't get a scan.
Any other questions? You will Phil disappears just behind.
So just you said just you can drain abscess and as loose seton just to mature the tract and then use SSP. So what's the time frame between doing this?
Oh, okay. Yes, and I've made it sound like you should drain the abscess and place the seton at the same time, which is one of the cardinal rules to avoid, in my opinion. Okay, a primary abscess should not have a seton placed within it, in my view. Okay, there are 2 systematic reviews that say that that's wrong. One of them a Cochrane review. They are wrong. Okay, I am right. You should not place a seton in a primary abscess. More than half of primary abscesses with internal openings at the time of drainage will vanish. Okay, it's better to do nothing than to do a sphincter preserving procedure 6 months down the line in terms of healing. So you should leave them. Recurrent abscesses in Crohn's disease are a different kettle of fish, and then I might place a seton at the same time. But what you actually asked me was how long you should leave the seton before you do the sphincter preserving procedure. No one knows. Probably 3 months. I would always leave it 3 months and sometimes 6.
Anyone else?
If you don't find any internal opening
Mm.
in that situation, like you've done everything, dye, hydrogen peroxide, probing, it's very, and even the MRI did not show any internal opening. It just goes close to the sphincter area and then it stops there. But the symptoms are all suggestive of he's got recurrent, abscess and discharge.
So the answer is you should back off. When you go hunting for an internal opening and you can't find it, and then 45 minutes later you suddenly find it all in a rush, you haven't found it, you've made it. And that makes curable fistulas incurable. And the classic situation is the transsphincteric fistula from external to internal opening with a higher internal opening in the same line. And sometimes the true internal opening will be background at 6 o'clock because it's horseshoeing in the insphincteric space, that difficult one that I showed you the picture of with my video. That's the one where people get to the point where the fistula turns the corner, and they don't turn the corner because they can't find it. It's very difficult sometimes, impossible sometimes. Sometimes it hourglasses right down to nothing in the insphincteric space and you can't get through it. And in that situation, they will find their way through to a new opening in a straight line from the inside to the outside, and it looks brilliant and it's iatrogenic. And that's the thing really to avoid. So the answer is if you can't get the probe through and you've tried hydrogen peroxide is my own favourite. I don't use blue dye because it just turns everything blue unhelpfully. But hydrogen peroxide, and you've tried thinner probes, although they carry their own risks because they're so narrow in that situation, then back off. And I will do that. From time to time, Maria, one of the fellows here who works with me, and she see me swear and bleat and cry and then stop. Because ultimately, if you can't find the internal opening, the right thing to do is to stop and then come back another day when that opening may well be there, use the hydrogen peroxide again, and if you can't find it, phone a friend.
Thank you.
Thank you very much. Good questions. Just what we're after. Fantastic. Thank you very much indeed, Phil.
Thank you.
Brilliant. So now it's my pleasure to welcome to the stage Dr. Ayesha Akbar, who's been a consultant here at St Mark's since 2010. She did a PhD at Imperial in molecular basis of colonic hypersensitivity, and she's on the council at the BSG and also elected fellow of the Royal College of Physicians. Thank you very much indeed.
Thank you, Chris. So,
Sorry, let me done this, shouldn't I? Beg your pardon.
It's all right. While Chris is pulling that up, I have to make apologies that I can't hang around at lunchtime either, but I am here in the coffee break and most of the morning, so please feel free to find me if you've got any further questions. So I'm here to talk about the medical management. I'm a physician, not a surgeon. So it's really how do we medically manage our patients with perianal Crohn's disease. So just a declarations of interest slide there for you. And just to put into context, so my subspecialty interest is inflammatory bowel disease, and we see many complex patients, both locally and tertiary referred. So we probably see a disproportionate amount of perianal Crohn's disease in our clinics. Perianal Crohn's disease is awful. You all know when you manage these patients, it's bad enough when they've got Crohn's disease, and when they've got horrible fistulating disease on top of it, it can be really awful for these patients. There's a significant morbidity associated, and it affects them negatively on a day-to-day basis. So a lot of young females will come in and it affects their sexual life, their daily life. They feel awful, they've got this daily discharge. It's really a nasty disease to have. It's really important that we approach these patients with the patient at the center of everything that we do in a multidisciplinary approach. And first we used to say the surgeon, the physician, and now we're very much including the radiologist in that as we're getting better with our scanning techniques, and we're looking much more to treat to target and make sure we're actually getting scan radiological improvement as well as clinical improvement. And as Phil alluded to, a lot of the clinical trials have been just looking at clinical symptomatic improvement, but now we're looking at radiological improvement as well, and that's very important. Despite our advances over the years, we're still reaching remission rates of about 50%, even with our joint multidisciplinary approach at the moment. So it's great to see some novel techniques coming out, things like stem cells, because we're still not there in really effectively managing our patients. So if we look at our cohort of perianal fistulating disease in the background of Crohn's disease, the various studies report the incidence of about 14 to 38%. Phil's already shown you some nice diagrams, but basically, broadly speaking, we can categorize them into simple fistulae, where they've got a single orifice, or complex fistulae, where they're high lesions, multiple openings. Rectovaginal fistulas are active disease associated with them. And MRI is important in this group of patients, the patients with Crohn's disease. And I know Phil said we'll examine the patients, but majority of our patients, we will get a baseline MRI if they've got fistulating disease, so that we can then map their progression and how they're doing along their disease course. Quick diagram to show the difference between the simple and the complex that I've already described. And it's really the complex group of patients, so it's a difficult cohort that we're really managing in our multidisciplinary approach. We must remember that if these patients have got active luminal disease, if they've got active proctitis, that's often a driver for the ongoing fistulating disease. So it's really important that us as physicians achieve mucosal healing, and that's an important endpoint for our patients. So we endoscopically evaluate these patients, look for active proctitis, and if there's active proctitis there, we need to get the medical management right so we can at least heal their mucosa. Often we need surgery as well. It may be an EUA, it may be a ceton insertion, it may be more aggressive surgery, and Phil's already gone through the surgical options. But basically, in summary, it's the combined medical surgical approach that is really important. Phil's already shown you some diagrams, but this is a patient, and you can see exactly what he said. If you're going to put cetons in, don't do the 50-knot ceton because it's not very nice for patients. We see really thick cetons, multicolored cetons, and first thing we'll do when they come here is take that ceton out and put a more comfortable ceton with a single knot. If you look at the literature and medical management of these patients, what do we have out there? So we've got antibiotics. The most commonly used antibiotics for perianal Crohn's disease are metronidazole and ciprofloxacin. But actually, if you look at the literature, the evidence is limited. There's small studies. Ciprofloxacin, for example, there was a randomized control study. N was only 10. The remission was 30% with ciprofloxacin group versus 12.5% with placebo group. However, the patients often feel better, and if they're having a flare of the disease, it's a nice middle management. If you're waiting for an EUA to actually put them on some antibiotics, their drainage decreases and they feel better for a period of time. If it's a simple fistula with one opening tract, maybe you can get away with just giving antibiotics alone, and you may actually win and even get cure. However, in complex disease, we're probably using it as an adjuvant to other therapy. Also, the problem is with complex fistulae, if we give them long-term antibiotics, I don't know how many of you have had metronidazole. It's not the nicest antibiotic to have, lots of GI side effects, doesn't mix well with alcohol, so your patients don't thank you for it long-term. There's a chance of peripheral neuropathy, and with ciprofloxacin, a chance of tendinitis as well. So always counsel your patients if you're going to put them on it long-term. Like I said, we use it often in combinations, and you can use other broad-spectrum antibiotics as well, such as coamoxiclav, which give good tissue penetration if the patient isn't penicillin allergic. Thiopurines, we've used azathioprine for a number of years now, and if you look back at the literature again, there's a meta-analysis. The problem with a lot of these meta-analyses, you go back and look at the studies, and the endpoints are very different. Fistula closure was included as a secondary endpoint in some of these studies, and they reported a clinical response rate of 54% with azathioprine compared with 21% in placebo. But as I've said, the endpoints are varied, so how do you actually interpret that literature? There's very little data out there for methotrexate, so it's not an immunosuppressant that we usually use for our patients with perianal Crohn's disease. Anti-TNFs, they've completely changed our management in the last 10 years or so, and patients with complex disease, we will move them as physicians very quickly onto anti-TNF therapy. There have been 2 good prospective clinical trials with fistulizing Crohn's disease in particular and infliximab. First trial, 94 patients, 90% perianal fistulae, 10% abdominal with Crohn's disease. And the primary endpoint showed there was a 50% reduction in fistula drainage observed in about the primary endpoint was that they achieve a 50% reduction in fistula drainage. And that primary endpoint was achieved in 68% of patients who were given infliximab 5 milligrams per kilogram dose and in 26% of placebo, so that was clinically significant. Complete healing was the secondary endpoint, and it was achieved with 55% of patients on infliximab versus 13% in the placebo group. So that was the first study that really looked at perianal Crohn's disease. There was a second study, Accent 2, which Sands carried out in America as the primary investigator, and that looked at infliximab given as an induction dose and then ongoing maintenance therapy, which is the practice most of us use now. 304 patients were included in that, so quite a big study. 195 patients, i.e. 64%, achieved a response, and they were then randomized after induction to receive maintenance infliximab or placebo. Primary endpoint was the time to loss of response to infliximab, which was much longer as you'd expect in the infliximab treated group compared to placebo. In the infliximab treated group, they went to over 40 weeks doing well versus 14 weeks in the placebo group. At week 54, 1 year data, we saw complete healing of fistulas in 36% of the infliximab group, 19% in the placebo group. So reasonable data, but still you're getting 36% healing of these fistulae with ongoing infliximab. When you look at other biologics, we look at adalimumab, combining it, and we were talking about antibiotics before. Actually, if you combine with antibiotics, add in ciprofloxacin, there is a small study that shows that there was a benefit, an added benefit. So the adalimumab plus ciprofloxacin group, more of them achieved fistula closure, 65% versus 33% in patients given adalimumab and a placebo. However, if you looked at week 24 data, that was no longer statistically significant. So actually there's only a benefit at induction. Longer term, there's no longer any clinical benefit. So that really ties with our data. It's probably useful using this short term when you're trying to bridge that EUA or just getting things under control rather than long-term antibiotic therapy in conjunction with the biologics. When you look at the other biologics, there's some data for adalimumab, which is another anti-TNF agent that we commonly use, but that was a sub-analysis population group. It wasn't a study primarily looking at fistulating disease in Crohn's disease. It showed that a significant proportion of patients up to 2 years did well on adalimumab. There was another Spanish study, a retrospective multicenter study, which showed efficacy of adalimumab with remission rates in complex perianal fistulae, which they described as absence of drainage, again a clinical endpoint, in Crohn's disease of 41% at 6 months and 29% at 12 months, so that wasn't placebo-controlled. There's also data for certolizumab. Certolizumab isn't licensed in the UK, but is in America, another anti-TNF, which again, a subgroup analysis showed complete healing in 36% of patients treated with certolizumab versus 17% in the placebo group. that's just showing the CHARM data with adalimumab at week 26 and week 56. So those that do tend to achieve healing of the fistula, that is maintained through to week 56. So if the patients do respond, they tend to maintain response, but the important thing is that we need to maintain them on the biologics long term. If you look at the data out there, it says that anti-TNF plus EUA is the best modality to manage our patients, and that's the way that we do manage most of our patients. So when you combine EUA and ceton placement or fistula tract curettage with the anti-TNF, there's a better response rate, a lower recurrence rate, and a delayed time to recurrence in patients receiving infliximab and an EUA. And again, Gartner and al. Showed the combination of infliximab and ceton placement is better than ceton placement alone in Crohn's fistulas, 62% versus 43% efficacy, which is significant. And there was another systematic review and meta-analysis, which again shows that anti-TNF with surgical intervention is superior to anti-TNF therapy alone. So actually, this really backs exactly what we're doing in clinical practice, that joint management. So current randomized controlled trial is looking at, the PISA trial is actually looking at what is the best management of these patients. It's looking at ceton placement and sepsis drainage, and then patients will be randomized into 3 groups: chronic cetons and 6-mercaptopurine, so thiopurine, anti-TNF and 6-mercaptopurine with ceton withdrawal after 6 weeks, which is quite nice because often we ask the question, when do we take that ceton out? Do we take that ceton out? And the third group, which is mucosal advancement plasty. And then the fistula will be reevaluated, looking at how many reinterventions they've needed during that 1 year with a 1-year time point. So that would be quite interesting to see what actually is the best outcome, what is the best modality for these patients once they've had the EUA. So we'll wait the data from that. We have got newer biologics now on the market. Ustekinumab is also licensed for Crohn's disease. It's a monoclonal antibody. It blocks the P40 subunit via IL-1, IL-23. The nice thing about the newer agents, they're more specific, they're more targeted, and hence they cause less overall systemic side effects and less infection risks. Again, it's a subgroup analysis data from the immunity studies with ustekinumab, and they showed a fistula response was observed in 80% of patients in the combined ustekinumab group versus 45.5% in the placebo arm. But these are small numbers. It's a subgroup analysis. The study wasn't powered to look at fistula closure, and again, this is clinical response. Vedolizumab is another biologic agent which we use in Crohn's disease as well. At the moment, we tend to use vedolizumab second line for luminal Crohn's disease. Again, it's a more specific. It blocks the alpha-4 beta integrin on lymphocytes and stops lymphocyte cell trafficking into the gut homing molecules, so tackles gut inflammation there. So again, the side effects overall are less for the patient, more specific. Gemini 2 was a placebo-controlled trial specifically looking at Crohn's disease and vedolizumab. And again, this is a subgroup analysis. There were only 18 patients in the subgroup on placebo, 17 in the vedolizumab every 8 weeks, and 22 given vedolizumab every 4 weeks in the subgroup analysis for those with fistulating disease. Interestingly, those given vedolizumab every 8 weeks did better than the 4-weekly vedolizumab. The standard dose we give is 8 weekly. We sometimes dose escalate up to 4 weekly, and it showed that they'd have higher rates of fistula closure than the placebo group. But again, caution, these are very small numbers. So basically, if you look at the data out there, it backs anti-TNF use as first line. A lot of physicians use infliximab because that is the agent that actually was powered to look at fistula closure. Adalimumab has the advantage of being used subcutaneously, so patients can use it at home. They don't have to come up for an infusion regularly. So to be honest, as a physician, we would probably choose between infliximab and adalimumab as first line. And then if patients are refractory or failing, we then switch on to, we've got a choice now of vedolizumab or ustekinumab as a second line agent. What about other medical modalities? There is literature, and there was a lot of excitement initially about local injection of anti-TNFs. The benefit has, one, you don't get the systemic side effects because it's all locally acting. You inject into the fistula tract. 2, potentially a cost-saving benefit because the anti-TNFs come with a big price tag as well. And we think that, perhaps if we don't systemically immunosuppress them as much, they may do well. Small studies again, we were quite excited when the first series came out where infliximab was injected over repeat sessions. 10 out of the 15 patients, small cohort of patients, had complete healing after 3 to 12 sessions of injections. Tonelli looked at adalimumab patients, again a small cohort, 12 patients. Adalimumab 20 milligrams diluted to 20 mils of saline and injected into the fistula tracts every 2 weeks. They had a median number of injections of 7. And 75% of the patients had absence of drainage and 25% had improvement. Positive data, but small numbers. Again, the endpoint was clinical, not radiological. If you look at the trial study design, where do you inject? Do you inject into the fistula? Do you inject around the fistula opening? Do you inject anywhere in the tract? Where do we exactly inject? So there's lots of variables that are unknown there. So although there was excitement initially, this hasn't really taken off as a big technique. And this is just a summary of the various studies that are out there for the local injection. And like I said, small numbers, even though the data looks promising, it'd be very good to get a proper randomized controlled trial out to see if this actually works. Endoscopy does have a role in management of perianal fistulating disease. Of course, we want to have luminal assessment, and it's really important when we start therapy, we assess them at maybe 4 to 6 months down the line to see if we've actually got that mucosal healing or not, because otherwise that's actively driving the fistulating disease. Strictures are commonly seen with patients with perianal Crohn's disease, and if the patients have got a stricture, it's important that we treat that stricture, and we can treat that endoscopically by balloon dilatation. Sometimes we'll send the patients home if it's a low stricture with Hagar dilators to self-dilate. But it's really important we stop that stricture recurring. Endoscopic clipping, I know that Phil touched upon it in his talk. Again, small numbers of patients. There's a small retrospective study, n equals 10. 6 of the patients had Crohn's disease. The procedure, they said, was technically successful in all patients, and permanent fistula closure was achieved in 70%, but that's again small numbers, 7 out of the 10. Median time for healing, 72 days. But again, we don't know about the long-term efficacy, what happens at 1 year, we don't really know, and these are small numbers again. Easy to do though, because you can get in with an endoscope and just put the clips on. So really important, anti-TNF therapy in our complex patients early, plus minus immunomodulator therapy. Ensure drainage of all infection, EUA plus minus cetons, plus minus antibiotics. So just a very quick summary of what we're really going to do with our fistulizing Crohn's disease. Very simple. If it's simple, trial of antibiotics, consider fistulotomy, and Phil's been through some of the techniques. Complex disease, we want to go in, we want to manage it with the surgeons, get an EUA and ceton, and put them very quickly onto anti-TNF therapy, scheduled maintenance therapy, plus minus an immunomodulator, depending on the complexity of their disease. So in summary, it really is all about the multidisciplinary approach, working together with our surgeons. We now try and get our patients very quickly in for EUAs. The important thing with these complex patients, they're likely to require recurrent EUAs. It's not just a simple, we'll do an initial EUA, put you on the biologic, and there you go back to the physicians. They flare intermediately, and then they should go back, have an EUA, clean it out, continue with their biologics. And it's really important that you explain that to the patient. Sometimes when the disease is really bad, we have to, as you're aware, defunction them, try and settle the rectum down, continue hitting them with biologics, and then look at potentially rejoining them. Quite often when these patients are defunctioned, it's a one-way trip down to potential proctectomy down the line, but at least they're then getting their head around the idea of a stoma. So if you initially counsel them and say, we're going to defunction you, we're going to see how you do. But it's really important, that multidisciplinary approach. And now at St. Mark's, what we do when the patients flare, they can easily call into our IBD helpline, and we'll try and plug them straight in for an EUA to whichever surgeon's got the shortest wait list, rather than get them up in clinic, assess them, because it's really important their sepsis is drained and treated, and we don't have an interruption in their therapy. We go for anti-TNFs first. There's data to support infliximab, less data for adalimumab, but nonetheless data there. Second-line biologics are now available if they're intolerant or refractory to the anti-TNFs. And the really important thing is, even with our multimodality, multidisciplinary approach, we're still getting fistula healing in only about 50% of patients. This is a chronic, horrible disease. We need to monitor, and we need long-term therapy for them. Thank you very much.
Thank you very much. That was excellent. It's so interesting to see how many trials are going on. That's what happens when industry's firmly involved with the promulgation of these drugs, which have changed practice completely. So I'm sure there's some questions from that, because I certainly thought of a few. but it's not me. It's all about you. Has everyone got excellent, Sam? Keep your thinking caps on.
Thanks, that's really interesting. So how long would you give someone on, say, infliximab before you decide is it working or not? How long does it normally take to get an effect if you think if they're going to have a good response to it?
So we normally assess primary response at about 14 weeks. We give them induction therapy, 0 to 6 week therapy, and then we wait to week 12 to 14 and we assess them. And all our patients on biologics will get assessed either with a phone call or a face-to-face visit to see if they're primary responders or not. And it's really important to tease out the primary versus the non-primary responders. If they're a primary responder, then we will absolutely continue therapy, and then it's good to at least continue to a year. This is not going to heal overnight. It's a horrible, nasty disease. There's that grey area of the patient who says they feel a little bit better, but they're not quite there. And again, in that group of patients, because we know these are good drugs, they're probably the best drugs we've got for perianal Crohn's disease, there's not a lot else out there, we would probably continue. If they're an absolute no response, I'm still going several times a day, then they're probably a primary non-responder, and it's not worth continuing then. These are expensive drugs. They do have potential side effects. So then we would switch them because we have got other agents out there now. If you're really not sure, then it may be worth doing a repeat flexible sigmoidoscopy to see if their luminal disease has changed at all. And if there is a partial endoscopic response, then we would then probably continue, yes.
3 or 4 months or so.
Yes, yes.
Anyone else?
I've got not that much experience with seeing people with biologics. Have you got a side effect profiles over a year? Is that a particular problem for patients or not?
So we'll always cancel patients. The biggest side effect is increased infection risk, as with all our therapies that immunosuppress. So thiopurines do. Interestingly enough, if you look at the meta-analysis data, the drugs which cause the greatest immunosuppression are steroids. So we still give a lot of steroids, but they're probably the ones that increase the infection risk the most. So there's increased infection risk, nasopharyngitis, rarely you can get rashes, arthralgias. The more serious side effects, there's an increased risk of lymphoma, a small but increased risk. That's usually increased over the years. And that's the main risk with them. But over 12 months, the main thing is infection, basically. A lot of patients get very worried when they're young and you talk to them, talk about things like lymphoma. So we've got quite nice patient palettes which help in their decision making to show actually the risk is relatively small in the bigger scheme of things. And it's that versus the horrible perianal Crohn's disease and the risk of complications down the line. So when you sit and speak to the patient, it's really important. We're helping empower them to understand that if we leave this alone, you know, we've got potential proctectomy at the end of the line. So it's getting that balance right.
Any other questions?
Active perianal Crohn's, which is discharging, but there is nothing to drain, like there is no underlying collection or abscess or anything. Do you prefer the medical treatment first before you do the EUA? And if you prefer the medical treatment, how long you wait?
So you're basically talking about a simple tract in essence. So I'd go in, I'd look if there's any proctitis there that's driving it, so then you can at least luminally control their inflammation. The majority of the patients, we'll go through the MDM, we'll look at their imaging, we'll have a joint sort of discussion, decision making. If there is stuff coming out, there probably is something there that needs drainage. You could put them on a course of antibiotics and see if they settle, but I'd want to know what the MRI looks like and make sure that there, you know, is there anything to drain? If there isn't anything to drain, then probably just go straight on to anti-TNFs.
Regarding the antibiotics, is it just normal 5 to 7 day course, or do you recommend a bit of longer course for Crohn's patients?
I probably recommend 2 weeks of antibiotics, ciprofloxacin and metronidazole altogether, if they can tolerate it, just to sort of hit it on the head and settle things down. And usually it's just, you know, getting things settled down and then moving on to more definitive treatment.
Hi, great talk. Thanks very much. I was just wondering, you touched on it when you mentioned the PISA trial, but what's your practice at St Mark's when to remove the cetons?
That's a very good question, and you'll probably get a different answer from everyone. So in the complex disease, quite often we will leave the cetons in. If you look at the literature, they will say reassess at 4 to 6 months. And if you're going to go for primary healing, that's probably the time where you want to remove the ceton to give it a chance to heal. Once it's been in long term, the tracts start getting epithelialized, you're probably never going to actually achieve cure, you're just going to achieve control. So if you are going to remove it, 4 to 6 months is probably the optimal time to remove it. If you're going to do that, though, I'll always counsel the patients that there is a chance that things could get worse again. We're going to go back and put the ceton back in again. But if it's a relatively simple tract and you think you are going to be able to achieve complete remission, then that's the time to remove it. A lot of our patients have got complex tracts, like Phil's showing you, with several internal openings. In that group of patients, I think really we're aiming, and that's again setting expectations and having that discussion with the patient, saying, you know, we're aiming for drainage control here to try and achieve partial remission. Unlikely we're going to get complete cure, but at least improve your daily quality of life, so you're no longer wearing a thick sanitary pad, you're just wearing nothing or a little bit of gauze, and you can function with a normal sort of level of day-to-day living, and we control your luminal disease, so you've not got the frequency and the urgency to go. But it really depends on what their initial scan looks like.
So you'd be looking for a clinical improvement in terms of their fistula output?
Fistula, yeah, in a lot of the patients with multiple openings. But if they're simple 1 or 2 openings, then you could potentially remove it. And if you are going to remove it, 4 to 6 months is the optimal time.
Anyone else? I've got one question myself. About advancement plans. You mentioned advancement plans. I always rather fear doing advancement plans with Crohn's. I've been warned away from doing it just in case I make the whole situation 100 times worse. Have you seen people have success with advancement plans?
So, I mean, Phil's the better person to ask on the surgical thing, but we're quite fortunate now. We've got plastics involvement as well. So again, it's going to be very much a multidisciplinary approach. So we have done some. Sometimes they do break down badly, and sometimes they do well. But I think it's a small cohort of patients, and I think again it has to be careful discussion with the patient to understand the risks and the benefits, the multidisciplinary team support, because having plastics on. It can work. Sometimes they need waft after, you know, long-term, so not waft. Sometimes they need sort of surgical drains afterwards, you know, vacuum-assisted drains, and it can take a while to heal up, but they can have good results as well.
But those that don't, presumably it's a bit of a disaster if they fall apart.
Yes, yeah. It is an absolute risk, but then, you know, that's where it's all about discussion, careful discussion with the patient and counselling them. You know, are you happy to live with a ceton in? Do you want the chance of cure, in inverted commas? So I think it's patient selection and managing the patient expectations and carefully counselling them about the potential, you know, risks of the outcome. Because even if you do a proctectomy, we've always got the risk of the wound breakdown. And a lot of these patients with nasty disease, it's not the easiest.
And do you see a lot of perianal disease in those without proctitis? I know there's associated with terminalitis.
There is. So you do see a cohort of patients absolutely without proctitis, active proctitis, but ongoing fistulating disease. But it's really important that we do look for that proctitis, because if it is active, that we do adequately control them. But even when we've got the proctitis under control, the fistulating disease can still be an issue and a problem.
But that would change your approach. If you've got a simple Crohn's-associated fistula, in the absence of proctitis, you'd try some antibiotics, for example.
Yeah,
but of course,
absolutely.
if they had proctitis, you'd be going for different treatment with your biologics.
Yes.
Yeah. Anyone else? Right. Well, it's the end of the first morning session, so it's a cup of coffee or 2, and then we'll be on to the next session. Thank you very much.